Okay, good morning, everyone. So we begin the class now. Today's lecture. Okay. Right. The screen, can you all see the screen? Okay, thank you. So today's lecture is about drugs that are used to treat Parkinson's disease and Alzheimer's disease. Right. These two diseases have one thing in common. They are neurodegenerative diseases. Right. That means there is a deterioration in the central nervous system that is progressive, that it will worsen with time. Right. So as usual, the learning outcomes is that you're able to recognize the structures of these drugs that are being used to treat these two diseases, as well as to relate the structures as much as possible to the mechanism of action. Okay, let's start, because today we have two diseases to cover: Parkinson's disease and Alzheimer's disease. So I will start off with Parkinson's disease, okay, and then move on to talk about the drugs. Okay, I want to bring you again to see this these pathways in the brain that is the major dopaminergic pathways. So there are essentially four major pathways that secrete the dopamine as the main neurotransmitter, right? And one of them that is involved with the movement, control of movement, is the nigrostriatal pathway. I think you've heard of this for quite some time already in physiology, right? So it starts from this place called the substantia nigra pars compacta. That's this group of nerve cells, starting from here, the cell bodies that would radiate until it reached to this section, the striatum. That is why the name is nigrostriatal pathway. So this is the pathway, and the main neurotransmitter that is emitted or secreted by these nerves are dopamine. Now, to make things simple for you, the one of the cause of Parkinson's disease, there's some problem with the movement of the sufferers of Parkinson's disease, right? It's because of there's a drop in the function or the dopamine itself, in this pathway. So there's a drop in the activity of dopamine in the nigrostriatal pathway. So the approach to treat Parkinson's disease can be divided into three ways. The first is, of course, since there is a drop in the activity of dopamine, one way is to replace the insufficient dopamine with something, right? So it's called replacement therapy, and we use levodopa or L-dopa. Throughout my lecture, I think I will be using levodopa, right? Levodopa. Stimulation of dopamine receptors, right, with agonists. So by activating the receptors, the dopamine receptors at the post synaptic nerves with dopamine receptor agonists. Thirdly, we can also boost up the activity of dopamine by reducing its degradation. So the dopamine, when it is secreted, it will be taken back, or it will be degraded or changed, right? Degraded. So we reduce the degradation with inhibitors such as MAO inhibitors and COMT inhibitors, because these are the two enzymes that are involved in degrading dopamine into metabolites that will be excreted. So this is the pathway that, or the biosynthesis that you should understand in order to understand how the drug works. So I've just mentioned the two enzymes, MAO, monoamine oxidase, and COMT, catechol O methyltransferase. These are very important in the particularly in the catabolism or the degradation of dopamine. Let's start with how dopamine is made in the central nervous system. Right? It starts from taking L-tyrosine, the amino acid that is the starting material, right, to be made into L-dopa, right? L-dopa, right, by means of adding on one alcohol over here, or one hydroxyl on the phenyl ring, and then this is followed by, this is also happening in the nerves, in the central nervous system, with the enzyme dopa decarboxylase. Decarboxylase, you can see here from the name of the enzyme, it's removing, this enzyme functions to remove the carboxylic acid of L-dopa to form dopamine, and that's how you generate dopamine. Dopamine can also be further converted to noradrenaline for nerves that neurons that are not adrenergic, right? That secretes noradrenaline. Okay, so here there are the two enzymes that will further convert dopamine into something else, and then it will be secreted. One is monoamine oxidase, or MAO, would change the amine here into an aldehyde, right, known as dopal, right? This is the product of the conversion of monoamine oxidase. The other one is COMT, catechol O methyltransferase, which will methylate one of the alcohol of the on the ring here, because this is a to refresh you on what is catechol. This is a catechol, right? This is two alcohols side by side on a ring. It's a catechol. So this enzyme will transfer one methyl to one of the alcohols, so change it to a methoxytyramine, which is also considered a inactive metabolite. So uh, to supplement the insufficient dopamine in the central nervous system, this the simplest way is to give dopamine. Unfortunately, dopamine can only be produced within the central nervous system. Uh, Therefore, you cannot give it from the outside. Right? That means you cannot give it like a drug. Give it uh, because dopamine cannot pass through the blood-brain barrier. The barrier that separates the system, the blood stream, from that of the brain inside. So you can see if you uh, the way to do it is to uh, use the precursor for dopamine, which is L-DOPA, right? So L-DOPA can be given because it can be taken in like an amino acid via a amino acid transporter on the blood-brain barrier, on the cells, on the lining of the endothelial cells that lines uh, the small blood vessels of the brain, right? But the bioavailability, the amount that is available is also quite low. You see, that's from the dose that is given orally, only 1% manage to reach the brain, to enter, cross the blood-brain barrier and enters the brain. And then it is, uh, by means of the decarboxylase enzyme, it is changed to the active dopamine. So if levodopa or L-DOPA is given alone, you will need at least 3 to 6 grams uh, to compensate for this lost, this uh, this very big loss, right? Um, because of the presence of this enzyme, decarboxylase, the dopa decarboxylase in the peripheral region. So not only in the brain we have dopa decarboxylase, we also have uh, decarboxylase enzymes uh, in the peripheral tissues. So that is why levodopa is given together with peripheral dopa decarboxylase inhibitors. So they come together, L-DOPA plus a decarboxylase inhibitor such as carbidopa, like this. So this is a structure of carbidopa. You can see that there's some resemblance to the to levodopa, right? But slight difference. For example, there's a hydrazine over here. Instead of an amino group, an amine of the amino acid, but here you have a hydrazine, right? That is the difference. Here is another example of a inhibitor, decarboxylase inhibitor that is put together with levodopa, and it's a combination. They put it together in one pill uh, uh, as a combination treatment, like this benzorazide, right? So this selectively inhibits dopa decarboxylase in the peripheral tissues and not the dopa decarboxylase in the brain because they cannot cross the blood-brain barrier. With the use of this combination of uh, decarboxylase inhibitor plus levodopa, the dose of levodopa can be lowered down significantly to this much, uh, as low as 0.2 to 1.2 grams a day. So that is levodopa. This is the main treatment of the, you can consider it's a first line treatment for Parkinson's. Now here is another example that of a drug that can be put to supplement or that can work together with levodopa. That is the uh, dopamine agonists. So these are drugs that bind to the dopamine receptor and activates it, right? Like dopamine. It works like dopamine, right? So you can see it's not surprising that this drug apomorphine is modeled after dopamine. Now, dopamine has a certain particular conformation that is active, that it assumes. Now, because of the rotational bonds here, here, and here, so that means you can see that dopamine can assume various conformations. It is free to change from one conformation to another. But this conformation here is the active conformation when it binds to that it assumes when it binds to the receptor. So apomorphine is like a rigidified uh, version of dopamine, where it is being tied up into the active conformer of dopamine. Right? It can bind to both D1 and D2 agonist receptor. So it can it is agonism against these two receptors, type 1 and type 2. But the type 2 is the one that figures the most, particularly in Parkinson's disease. So it can control the refractory uh, dysfunction that happens when levodopa is not working. So when there are times when uh, there is levodopa doesn't work, right, uh, across the treatment period. So these are called fluctuation in the treatment, or on-off syndrome, right? So this can be put together to add on to levodopa. Very poor oral bioavailability because of first pass metabolism if you give it orally. So usually it is given subcutaneously as an injection, or it can also be given through an infusion. One of the problems of apomorphine is that by uh, agonizing, causing activation of dopamine receptor, it can also cause another side effect, that is emesis. It can cause vomiting, right? This is because of the dopamine activation at the chemoreceptor trigger zone in the brain, right? By activating this can cause someone to vomit. So this is the problem with apomorphine that you have to watch out. The second class of dopamine agonists that activates this receptor is the ergot type, right? So this is a structure, the main representative of an ergot compound. This is known as bromocriptine, right? It is derived from because it has this ergotamine core and is derived from the ergot alkaloid. The ergot alkaloid comes from this rye that's been infested by 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 this fungus, this ergot fungus, and this does then produce this type of substance, or ergotamine. So it has the body of an ergotamine here. So in within structure. So that's why it's called an ergot uh, uh, compound, right? An example is bromocriptine, which is widely used because especially we want to activate dopamine receptor. So bromocriptine is one of them. It can activate it. Very good oral bioavailability. So this is the dose. Uh, it can also act because of its agonism on the dopamine. It can also act to uh, reduce prolactin. So it's an anti-prolactin, right? So it has okay. So another example, another derivative is cabergoline. Cabergoline compared to bromocriptine has a uh, longer half-life, right? Longer half-life. Uh, but the problem is that it may also have cardiovascular side effects because it also binds to another receptor, serotonin receptor, when it's given at high doses. So this can also affect the heart or the cardiovascular system. This is the thing about this drug, right? Another example is this lizurite, which is usually given as a transdermal patch. So another dopamine agonist is this, right? So this is also quite quite commonly given, also to supplement levodopa treatment and to control the period when there is the refractory period, where there is a time of the effect of the levodopa is being is not there, so, right? So that you can, so that to maintain the control, maintain the control when this happens, this on off episodes. This is pramipizole, right? Pramipizole. So you can see that it has a heterocyclic structure over here, right? Uh, it is an amine, and it also has a chiral center. So particularly, it is an S configuration. It has an S configuration. Another example is ropinirole, right? So this works hand in hand with levodopa and can actually spare the dopamine. So it can have dopamine sparing effect, uh, which can actually replace levodopa as a first line treatment for younger patients, because of it spares the need of the nerves, of the neurons to produce dopamine. It itself will act as dopamine. Okay, so those are the dopamine supplement with levodopa, as well as agonize the dopamine receptor. Now we come to another. These are the inhibitors that try to not try to they will reduce the degradation of dopamine by inhibiting monoamine oxidase. One is selagiline, and the other one is rasagiline, selagiline and rasagiline. So they all share this common property. They have a propagyl amine, right? Right, 3 carbons ending with a triple bond, right? A triple bond. So this is a propagyl amine, because it's attached to an amine. Uh, com- uh, these are the two alternatives. Well, selagiline has something you have to keep note of, is that because of its resemblance to amphetamine, and when it is metabolized by the liver enzymes, the CYP enzymes, it can cause a N dealkylation, removal uh, of this alkyl, which is actually the propagyl, will be removed. The propagyl group will be removed from the nitrogen to form something that looks like amphetamine, which would which can potentially cause cardiovascular side effects because it is active, right, on the heart, right, on the heart, right. It can cause to both either hypo or hypertension, and also tachycardia. So this is one thing you have to watch out, because of what it can perform when it is get metabolized. Uh, Whereas rasagiline, this does not happen because it would not produce amphetamine-like metabolites. Okay, lastly, this is the another inhibitor. This one is an inhibitor of the catechol O methyltransferase, COMT, and this is exemplified by this drug entacapone. Right? Entacapone looks like this. It's this the only one that is currently being used. Okay, so those are the drugs to treat Parkinson's disease, right? you I think you will be briefed on about the clinical features of the Parkinson's disease. When there's a disturbance in motion, what will happen to the patient? What you can see in the patient. Uh, okay, now I'm going to move on to another neurodegenerative disease known as Alzheimer's disease. This is quite a complex disease because we found that it can be caused by many factors, multifactorial. So it is you can say that it's a not a easy to treat disease. At best, the drugs that we use can only treat the symptoms of the disease. For example, we can see here there are several things uh, that may cause the degeneration of the nerves, particularly in the cortex, right? And those that secrete uh, acetylcholine, right? So there is a one of the reason is there is a drop in the activity of acetylcholine when these nerves start to degenerate, right? Or start to die off. So one way is to have drugs that inhibit uh, the hydrolysis of acetylcholine. So we have these acetylcholine esterase enzymes, right, that will bring back in the acetylcholine neurotransmitter and uh, hydrolyze it back into choline and acetic acid, right? So we have these drugs that reduce the degradation of acetylcholine by inhibiting acetylcholine esterase. Other factors are like inflammation, right? Cells that cause inflammation may also, in the long run, lead to the degeneration of the nerves. So nerves dysfunction, neuron dysfunction, and also lost. The other culprit is that of the formation of uh, these toxic proteins called the amyloid beta. So this is another feature or cause. Actually, it is considered a feature that you see in the disease, right? A hallmark. But they believe that this is also the cause, right? Having this present in the brain of Alzheimer's patients uh, leads to uh, the degeneration of the nerves. Another one is too much excitation by another nerves, over excitation, excited toxic. So this is actually bad. The over excitation is actually toxic. For example, one of the excitatory uh, nerves are those that secrete glutamic acid, right? Glutamate, or these are the glutaminergic nerves. So here is where the current available treatments come in to address the problems. One is to inhibit acetylcholinesterase, and the other one is to inhibit the excitatory nerves. Right? So let's talk about the acetylcholine inhibitors, acetylcholine and esterase inhibitors like rivastigmine. So rivastigmine is a carbamate. You can see here it has a carbonate, and this is the essential group that functions to carbamylate the enzyme, the cholinesterase, and therefore inhibits it. There, it binds because of the carbamylation. Therefore, the binding happens for a longer period, a longer duration. So you can say that it is not irreversible. That means it's not like the phosphate insecticides. Those are toxins that will actually kill your enzyme, so causing irreversible inhibition. Right? You learned this. I guess before in peripheral nervous system, right? So they just bind there for a longer period, so they are pseudo irreversible. It's given orally as a capsule. Uh, this is the dosage, 12 milligrams once a day, or it can also be given for a smoother drug profile by attaching it as a transdermal patch on the skin, which would produce or deliver this much of a dose across 24 hours. So the profile given by transdermal patch is better. There's an advantage there, because if you give it once a day like this, the dose in the drug profile in the blood, it goes up and it goes down very erratically, right? It's sudden and then drops, sudden drops. So the control is not so good. So this transdermal delivery uh, uh, provides a smoother drug profile for to maintain a not so fluctuating kind of uh, action, right? Uh, Partly because it has a short elimination half-life, right? So drug is not so stable, therefore the half-life is actually quite short. So if you give it orally, 12 milligrams given orally, so that is why it fluctuates, right? Uh, but the metabolism does not involve liver, not at all. It's just simply the hydrolysis of the carbamate. So the metabolite that you expect is something that where there is no carbamate over here. So the second drug that I would like to cover that is also a cholinesterase inhibitor is galantamine. This galantamine originates from the plant. You can say it's a natural product from these Caucasian snowdrop. These are flowers, but the place where they take is from the bulbs in the ground. Which this is the source of galantamine. So it's given twice daily as orally, and it inhibits the cholinesterase enzyme on the postsynaptic nerves, right? But it also has an additional mechanism that is it can also allosterically bind to the nicotinic receptor, right, and therefore cause an activation of the presynaptic nerves to therefore increase more of the acetylcholine, secretes more of this acetylcholine by activating the nicotinic receptor. Right? Donepezil is a third acetylcholine esterase inhibitor that binds quite well. Unlike rivastigmine, is a reversible binding, so it is competitive. It competes with acetylcholine for the cholinesterase enzyme. So here is a crystal structure that they managed to capture, showing donepezil going in very deep into the gorge, right, of or the very deep pocket of the enzyme where the catalytic site resides. So in this way, it blocks the entry of acetylcholine, therefore inhibits the hydrolysis. Longer elimination half-life, so more stable than rivastigmine because it doesn't involve hydrolysis of the carbamate. It doesn't have a carbamate. To significantly quite long half-life, up to 100 hours. That's about um, several days actually, right? But it gets metabolized to inactive metabolites also by the liver, the CYP enzymes. So possibilities that get debenzylated. There's a benzyl here, it gets removed. It can form N-oxide metabolites because of this nitrogen here is potential for to form an N-oxide or demethylated right? Here, over here, demethylated of this methoxyl groups. Right? Okay, lastly, this one is the one where I talk when I talk about excitatory overexcitation by the excitatory nerves that secrete glutamate or glutamic acid, right? So, particularly this receptor here, this receptor which is a uh, which is a ligand activated uh, channel. So it is a channel that allows the entry of calcium into the cells. So it is a channel, but the opening and closing of this channel requires glutamate. So that is where the glutamate neurotransmitter secreted by the nerves will go for the postsynaptic nerves that has this receptor, this NMDA receptor, which is a ligand activated channel, which will open when it is bound with a glutamate, right? So what this drug here does is it this is a drug that looks like a cage, right? This kind of cage-like structure containing entirely of carbons. The 1, 2, 3, 1, 2, 4, 5, 6, 7, 8, 9, 9 carbons uh, coming together, bonded together to form this cage. You can see this looks like a cage. This is an adamantane, right? Uh, so this drug memantine is a adamantane that has amino group on it at one position and two methyl over here. So it's a chemically you can say it's a 1 amino 3,5 dimethyl adamantane. Right? So this adamantane structure, it is found that it it inhibits the MNDA receptor by blocking the entry, the point where calcium ion is supposed to go in uh, to activate the postsynaptic nerves, right? So it blocks this, so there is it inhibits the entry of the calcium into the channel. So even if the presynaptic nerves continue to secrete glutamate to uh, to bind to to the MNDA receptor to open the channel, but the channel cannot allow the drug does not allow the entry of calcium because it acts over here at this the opening of the channel, right? So essentially these are the few drugs that are used for treating Alzheimer's so far that is clinically used. This is a disease that is difficult to treat, so uh, we are still trying to find drugs that work, because these drugs after some time they do not work. They cannot stop the progression of the disease. These diseases are progressive. They worsen with time. And so it is with Parkinson's disease. Okay, so so these are the list of drugs that I mentioned today. Levodopa and combination. Uh, most of the time is combination with the inhibitor of decarboxylase inhibitor and these agonists, dopamine agonists, as well as uh, MAO inhibitors and COMT inhibitors. As for the drugs to treat Alzheimer's are these cholinesterase inhibitors as well as memantine. These are the ones that we have currently. Okay, you can look up Foy's textbook if you want to read more. Okay, so I'm done with today's lecture. I open to to you for one or two questions.
Doctor, I have a
Mm.
question. For bromocriptine, it's mentioned that it can act as antiprolactin. May I know how is the action, like why it can act as antiprolactin?
All right. So one of the one of the four pathways that secrete dopamine, the dopaminergic pathway, is the one that goes from the pituitary gland. Remember, goes from the pituitary gland down to the hypothalamus. Right. That if you remember the lecture uh, on antipsychotic drugs, the classical antipsychotic drugs that works by by antagonism of the dopamine receptor, right? So if you block dopamine, that means you antagonize the receptor, inactivates it, using, for example, haloperidol, right? Haloperidol, the antipsychotic drug. So it will block the dopamine receptor on that pathway, the from the pituitary going to the hypothalamus. That is the place where when you block it, it would cause overproduction of uh, prolactin. It will secrete lots of prolactin, and that would cause other side effects. For example, things like the enlargement of the breast, uh, uh, gynecomastia. These are some of the problems when you block the receptor, the dopamine receptor, right? You cause increase in prolactin by this pathway. Whereas if in the case of the dopamine agonist, it activates the dopamine, and then this would activate the dopamine activity in this pathway, so that uh, it would actually this effect would then reduce. It is actually it has a negative effect, so it would reduce the prolactin, right? So it is we can call it an anti-prolactin drug. Well, one of the treatment, not besides the treatment of Parkinson's disease, where bromocriptine plays a role. You can see that no surprising. You don't be surprised that next time someone, how come this patient he's not having Parkinson's, but he's been prescribed with bromocriptine. But this patient's problem may be hyperprolactinemia. There is a problem. This is an endocrine problem, endocrine disorder to do with the pituitary gland. Right. So that one also we use bromocriptine because of its agonism on the dopamine receptor, therefore reduce prolactin. While the other way, if you antagonize dopamine, then it will on that pathway, the pituitary pathway, it will be the other way, the opposite. It will cause more prolactin to be produced.
Okay, thank you, doctor.
So, there are some materials outside England. You can continue. If you want to post any questions, there is also Q&A over there. I also have this self-test for you in England that you can try on your own time. Okay, so there's nothing else. That's all for this class. Thank you for your attention. I will come in again in the next class. Next Wednesday. Last. Right. So okay. Nothing else. I'll end the session. Goodbye. Thank you.
Thank you, doctor.
Thank you.